Hello students, I am Dr. Aditya, Assistant Professor from the Department of Oral and Maxillofacial Surgery, Vinayaga Mission Sangracharya Dental College and Hospital, Salem. Today we are going to discuss a topic about impacted third molar surgery and its complications. So we will come to the synopsis. We are going to cover the definition, theories of impaction, causes of impaction, classification of impaction, frequency of impaction, assessment, management and complications. Definition: according to WHO, an impacted tooth is the one that is unable to fully erupt in its normal functional occlusal position, location by its expected age of eruption because it is blocked by overlying soft tissue, bone or another tooth. So, theories of impaction given by Durbeck, there are Mendelian theory, phylogenetic theory, orthodontic theory, endocrinal theory and pathological theory. Causes of impaction: Berger has classified the causes of impaction into two major categories: local causes and systemic causes. Local causes comes under lack of space due to underdeveloped jaw, long retention or premature loss of primary tooth, irregularity in position and pressure of an adjacent teeth, the density of the overlying and surrounding bone, long continued chronic inflammation with resultant increase in density of the overlying mucous membrane, acquired diseases such as necrosis due to infection and abscess. Systemic causes: it can be classified into prenatal causes, postnatal causes and rare conditions. Prenatal hereditary causes. Postnatal causes include anemia, rickets, congenital syphilis, tuberculosis, endocrinal disturbances and malnutrition. Very rare causes like cleidocranial dysplasia, oxycephaly, progeria, achondroplasia and cleft palate can also influence impaction of tooth. Classification of impaction: we have ADA, AAOMS classification, classification based on nature of overlying tissues, Winter's classification, Winter's war lines, Pellin-Gregory classification, Warface assessment and Pedersen difficulty index. So, Winter's classification, this was given in 1926. According to the angulation of the third molar with the angulation of the second molar, the classification has been given. It divides the impaction into mesioangular when the degree is between 10 to 80 degree, distoangular, vertical, horizontal, buccoangular, linguoangular and inverted impaction. Winter lines, Winter war lines, WAR goes for white line, amber line and red line. White line decides the depth of impaction. It runs along the occlusal surface of first and second molars. Amber line is a yellow line that runs along the apex of interdental bone to the distal aspect of third molar. Red line is a perpendicular line drawn from white line to the expected point of application of elevator in the third molar. So, when the red line is more than 5 mm, the impaction will be very difficult. Pellin-Gregory classification, this was given in 1933. This classification is based on the depth of the impacted molar and the ramus relationship of the molar. So, this has level A, B, C based on the depth of impacted molar, and class 1, class 2, class 3 based on ramus relationship. When classified based on this, level C and class 3 is considered to be the most difficult impaction. Warface assessment. Warface assessment has 6 factors: Winter's classification, height of mandible, angulation of third molar, root shape, follicle size and path of exit. Every category has scores. The more the score, the more difficult will be the impaction. Pedersen difficulty index, this was given in 1988. Again, we are considering spatial relationship, depth of impaction and ramus relationship to the third molar. The difficulty level is calculated as 3 to 4 score will be minimally difficult, 5 to 7 score is moderately difficult and the score 7 and above is considered to be very difficult. So, problems associated with impacted third molars: it usually interferes with prosthetic treatment plan, and retained third molars interfere with removable prosthetic treatment plans. Impacted third molars interfere with eruption of adjacent second molar and it hinders orthodontic tooth movement. Impacted third molars in the line of fracture interferes with fracture reduction and plating. So, it can be associated with cyst and tumors sometimes. Frequency of impaction. So, coming to the frequency of impaction, mandibular third molar is the most commonest tooth to get impacted. Following that, maxillary third molar, maxillary canines, mandibular premolars, mandibular canines, maxillary premolars, maxillary lateral incisors and maxillary central incisors follow the order. Order of frequency of mandibular third molar impaction. Most common type of impaction is mesioangular, which comprises of 43%. Following that, vertical comprises of 38%, distoangular 6% and horizontal 3%. Indications for third molar extraction: pericoronitis, management of unexplained pain, prevention of caries, root resorption of adjacent tooth, orthodontic considerations, teeth under dental processes, preparation for orthognathic surgery, prevention of odontogenic cysts and tumors, and prevention of jaw fractures. Contraindications: it is contraindicated in extreme of ages, compromised medical status, possible excessive damage to the adjacent structures, when third molar would be expected to erupt successfully and have a functional role in dentition, no history of pertinent local or systemic pathology, prosthetic considerations where it can be used as an abutment for FPD, socioeconomic reasons. Assessment of impaction. Assessment comprises of preoperative assessment, in which the clinical assessment and radiological assessment is done. Clinical, general and local assessment. In general assessment, we will see the age of the patient, general examination about the patient's condition and medical risk. Factors to be considered in clinical assessment: patient usually be complaining of pain. We should exclude other causes such as TMJ disorder, pulpitis or abscess of other teeth. Previous medical history, if anything, like cardiac illness, respiratory diseases, thyroid diseases, hypertension and diabetes have to be taken into consideration. Past dental history, difficult extractions, post-operative infections, bleeding. Extraoral features should be noted like the facial form, lymphadenopathy, paresthesia if anything is present, and swelling. Local assessment: intraorally, most important thing is the mouth opening and size of the tongue should be assessed. Extensibility of the lips and cheek in case of oral submucous fibrosis. Extensibility of the lips and cheek will be reduced. Also, the status of the dentition, lymph node involvement. Assessment of the impacted tooth clinically should be assessed in local assessment. Assessment of impacted tooth: is the crown visible or not, and the position and occlusal relationship of the opposing tooth. Distal of second molar for pocket formation. External oblique ridge should be assessed, and the distance between distal surface of second molar and anterior border of ramus. Also, the condition of the soft tissue overlaying the impacted tooth, whether it is inflamed or not, is it having pericoronitis or not, should be assessed. Radiographic assessment: radiographs like intraoral periapical radiograph, OPG, occlusal, linear cross-sectional tomography, modified linear cross-sectional tomography can be taken, whereas the last two radiographs are taken in case of to determine the buccolingual relationship of impacted mandibular third molar and inferior alveolar neurovascular bundle. So this is a panoramic radiograph showing horizontal impaction of both lower third molars, right and left side. Position of root to inferior alveolar canal. In the first picture, you can see the root and the inferior alveolar canal all separated. In the second picture, the root and the inferior alveolar canal are in contact. There is no dividing bone between the root and the canal. In the third picture, the root is grooved by the inferior alveolar canal on the lingual aspect. In the fourth picture, the apex of the root is grooved by the inferior alveolar canal. And in the fifth picture, the root seems to be tunneled by the inferior alveolar canal. All the relationship of the root to the inferior alveolar canal is very much important to be assessed, because after the surgical impaction of third molar, there can be now paresthesias. Relationship of inferior alveolar canal given by Hovey and Payton in 1960. There can be darkening of root, deflection of root, narrowing of the root, dark bifid apex, interruption of white line of the canal, diversion of the canal, and narrowing of the canal can be seen. Ideal time to remove third molar is usually when the root forms more than 1/3 but less than 2/3. Management: preoperative management is done thorough review of medical history, good quality of diagnostic x-rays as we discussed before is taken and assessed. CBCT is taken if indicated. Role of CBCT in diagnosis is it is required in the preoperative assessment when darkening of the roots and interruption of the white line are observed in the OPG. So systemic antibiotics plays a very important role, because systemic antibiotics given before the surgery were effective in reducing the frequencies of wound infection after third molar surgery. Surgical management: anesthesia, incision and elevation of mucoperiosteal flap, removal of overlying bone following that delivery of the sectioned tooth, smoothing and debridement of the socket, hemostasis, wound closure and postoperative follow-up. Local anesthesia, mandibular molars, inferior alveolar nerve block is given, maxillary molars, posterior superior alveolar nerve block and palatine nerve block or infiltration. Instruments, these are armamentarium used for impaction. Principles of flap design, the flap we raise should have adequate access. It should have the viability of the flap should be determined priorly, avoid vital structures, plan ease of repositioning, ability to extend the flap if need arises. We should give clean incisions. Types of flap design, Watts incision and modified Watts incision, envelope flap, L-shaped flap, bayonet shaped flap, triangular shaped incision, comma shaped incision, S-shaped incision, Smith and modified Smith incision, Berwick's tongue shaped flap. These are the types of flap that we can use. Watts incision, the image shows the Watts incision. The second image shows modified Watts incision, whereas the releasing incision is given distal to the first molar. Envelope flap, triangular flap is usually used in the maxillary impacted molars. Comma shaped incision, usually comma shaped incision is used for deeply impacted tooth. Berwick's tongue shaped flap, this is a lingually based flap. It is used for deeply impacted tooth again. So these are the intraoperative images of the lingually based triangular flap. Closure of the buccal based triangular flap is shown. Also the lingually based triangular flap is shown. Here if we can see, the base of the flap is from the buccal aspect. In the lingually based flap, the base of the flap is from the lingual aspect. So bone removal techniques, we have postage and stamp technique, Moore and Gilbey collar technique, lateral trephination technique which is given by Boulder Henry, lingual guttering technique, chisel technique through buccal approach, lingual split bone technique given by Sir William Kelsey Fry. So before coming to chisel technique, burr technique, Moore and Gilbey collar technique is the most common technique that we use. We use burr to gutter the bone along the buccal and distal surface of the third molar, and elevator is used to luxate and elevate the tooth. Apart from the burr technique, chisel technique through buccal approach, lateral trephination technique, lingual split bone technique can also be done. So lateral trephination technique, modified S-shaped incision from retromolar fossa across external oblique ridge to first molar. Mucoperiosteal flap is elevated and buccal cortical plate is trephined over third molar crypt. Burr is used to make vertical cuts anteriorly and posteriorly. In lingual split bone technique given by Sir William Kelsey Fry, a 5 mm chisel and mallet used to place a horizontal cut parallel to the cervix of the tooth. Buccal osteotomy should extend the full mesiodistal width of the crown to allow placement of a Kuplan elevator and the tooth is elevated. Comparison of chisel and mallet and burr technique. Chisel and mallet technique, the technique itself is difficult compared to burr technique. Patient's acceptance is more in burr technique. Chance of fracture of the bone is low in burr technique and healing of the bone is good in chisel mallet technique, because while using burr we have to use irrigation to cool down the bone, otherwise it will lead to necrosis of the bone and delayed healing. So postoperative edema is less, dry socket incidence is less, and postoperative infection chance is also less in chisel mallet technique. The advantage of burr technique is it is relatively easy to remove. The disadvantage in chisel mallet technique is it is difficult to remove deeply buried impactions, also impactions in elderly and edentulous jaws. Bone removal is also less predictable. Once the soft tissue is elevated and retracted, the surgeon must make a judgment concerning the amount of bone to be removed. Bone must be removed in an atraumatic, aseptic and non-heat producing technique with as little bone removed and damaged as possible. The amount of bone that must be removed varies with the depth of impaction, the morphology of roots and the angulation of tooth. No bone should be removed from the lingual aspect so as to protect the lingual nerve from injury. Tooth division. For mesioangular impaction, the distal part of the crown is divided and removed and the entire tooth will have space to move distally and come out of the socket. In horizontal impaction, most of the 3/4 of the crown is removed and then the entire tooth is removed in toto, or the roots can be divided and removed. In vertical and distangular impaction, again a part of the crown is section longitudinally and removed, and the remaining root can be removed in toto or removed in separation. Delivery of section tooth. Luxation of the distal segment of the tooth with rotation of the elevator distally is done to luxate the sectioned tooth and remove. Debridement of wound and closure. Thorough debridement of the socket by periapical curette. Smoothing of the sharp bone margins by bone file and round burr should be done. Thorough irrigation of the socket under the flap using the povidone iodine solution and saline has to be done. Initial wound closure is achieved by just distal to second molar placing a suture. Posterior relieving incision should also be sutured. Interdental area mesial to the second molar is sutured, and 3 to 4 sutures are usually sufficient. Postoperative instructions. Pressure pack should be given. Ice application should be advised within 2 to 3 hours of the procedure. Soft diet is advised for first 2 days. First dose of analgesic should be taken before the anesthetic effect of early wears off, mostly within the 1 hour. Avoid gargling, spitting, smoking or drinking with straw, and the instruction of using warm water saline gargling after 24 hours and mouth opening exercises should be given. Suture removal should be done on the 7th day of the procedure. Complications. During third molar surgery, there may be complications during intraoperative time, also during postoperative time. Intraoperatively, during incision, hemorrhage and injury to the lingual nerve can happen. During bone removal, damage to the second molar, slipping of burr into soft tissue and causing injury, extraoral or mucosal burns when we use the burr technique, fracture of the mandible when using chisel mallet, subcutaneous emphysema can happen. During elevation or tooth removal, luxation of the neighboring tooth or fractured restoration, soft tissue injury due to slippage of elevator, injury to inferior alveolar neurovascular bundle when it is placed very close to the root of third molar, fracture of mandible, forcing tooth root into submandibular space or inferior alveolar canal can happen, breakage of the instruments, and TMJ dislocation can also happen. Nerve injuries. 0.6 to 5% of all third molar surgeries are involved with nerve damages, of which 0.2% are irreversible. Inferior alveolar nerve causes immediate disturbance with 4 to 5% and permanent disturbance only in case of less than 1%. Lingual nerve immediate disturbance happens at the rate of 0.2 to 22%. Permanent disturbance only 0 to 2% has been reported. Buccal nerve injury is very rare. 96% inferior alveolar nerve shows spontaneous recovery within 9 months, better than lingual nerve, which is about 87%. Beyond 2 years, the recovery is usually unlikely. Tooth displacement in lingual pouch. So, when the lingual cortical bone is thin and the tooth root is oriented towards lingually, there is more chance the tooth or the root may get dislodged into the lingual pouch. Usually, the tooth or root gets displaced into the lingual pouch, whereas the fracture line occurs below the attachment of mylohyoid muscle. The tooth or root gets displaced into the submandibular space in that condition. Dry socket. 2% of routine extractions and 20% of third molar impactions can cause dry socket later. Moderate to severe pain which develops around 3rd to 4th day is a characteristic feature of dry socket. The pain is dull aching which usually radiates to ear. The socket will appear empty. There will be bad odor and taste, possibly excessive fibrinolytic. Because of excessive fibrinolytic activity, the blood clot may get disturbed and that will cause dry socket. Management. Gentle irrigation with warm saline followed by superficial suctioning. Pack iodoform gauze soaked with medications. Change the pack every day for 3 to 6 days. Intraalveolar medications like eugenol, topical LA, antifibrinolytic agents can be given. Analgesics are to be prescribed to the patient. During maxillary third molar surgery, the complications that can happen are fracture of maxillary tuberosity, oroantral fistula, displacement into maxillary sinus, dislodgement into infratemporal fossa, damage to adjacent second molar, prolapse of buccal fat pad. Fracture of maxillary tuberosity. If the operator anticipates such a fracture, avoiding reflection of the periosteum will provide the best chance of survival post-operatively. Displacement into maxillary sinus. If entire tooth is displaced, it should be removed as early as possible to prevent infection. According to Pogrel in 1990, initial attempt should be done with a suction at the opening. If it fails, irrigate with saline again and use suction. If again fails, Place the patient on antibiotics and nasal decongestion and plan cardiovalvular approach to remove the tooth or root that is dislodged into sinus. Dislodgement into infratemporal fossa. The tooth should be removed as early as possible to avoid infection. Put an incision and try to retrieve with a hemostat or Alice forceps. If it is not possible, wait till fibrosis occurs and tooth becomes stable and place the patient under antibiotic coverage. Damage to adjacent second molar. It usually happens during bone removal and elevation of the impacted tooth. Post-operative complications can be immediate or late. Immediate complications can be pain, hemorrhage, swelling, trismus, paresthesia. Late complications can be infection, dry socket, osteomyelitis, secondary hemorrhage and pain in the TM joint. Recent advancements. Recently, the erbium YAG laser has been used to remove third molar atraumatically. Advantages of the laser: it is less stressful, less unpleasant to the patient. There will be no vibrations or sounds. Sharp, clean cut through the bone and tooth can be done. It can be used for anxious patients. Disadvantages: compensate for tactile feedback compared to burr. The trismus will be more. It is a time consuming procedure and the instrument is costly. Use of endoscopic approach for ectopic mandibular third molar removal. Its advantages include: it causes less tissue damage, clear magnified visualization of operating field can be obtained, more conservative surgery with a precise dissection can be done. Disadvantages: again, it's a costly procedure. It needs basic equipments and good eye-hand coordination and training. Indications for general anesthesia: if the patient is allergic to local anesthesia or a medically compromised patient, uncooperative patient, psychiatrically affected patients and patients in need of comprehensive dental treatment can undergo general anesthesia and impacted third molar can be removed. These are my references. Thank you for watching my class.